Welcome everyone to the 102nd session of Virtual Shadowing. Tonight's session is a specialty spotlight in palliative care with Dr. Tamara McGregor. Actually, this is our second 2-year anniversary. And as always, you can reach out to us on Instagram at Virtual Shadowing or through our email, which is virtualshadowing@gmail.com. These sessions will be recorded and posted to our YouTube channel, which is Pre-Health Virtual Shadowing. If you could go to the next slide, please. Here is the Virtual Shadowing Working Group comprised of Taylor, Kiana, Elena, Shayan, Ali, Aditya, Christina, Ashita, and myself, as well as our 4 physicians, Dr. Fowler, Dr. Salazar, Dr. Wynn, and Dr. Rena. Next slide, please. Here are some of our upcoming sessions. So next week, we have an artistic approach to medicine. And the week after that, we have What Makes Us Human, exploring brain cells one at a time. Join us on Zoom or YouTube Live at 7 p.m. Central Standard Time for these sessions. And then on the next slide, as usual, we will have 2 Q&A sessions, one near the middle of the presentation and one at the very end. If you have a question, please put it into the chat as we go along. Don't direct message the questions to either myself or the speaker tonight, as we might not see them. Put it in the chat so that our team can collect them. And now for a few words from Dr. Fowler.
Can you hear me okay, Rohit?
Yeah, now the audio is clear.
Thank you. Welcome, everybody. It's so good to have you. You know, it's almost very sentimental each week now that we come together to present some really astounding clinicians and thinkers and scientists who talk about how they got to where they are, but their experiences in what medicine, whether it's medical school, NP school, PA school, and other fields, can bring to you and your future, but most importantly, to serving the needs of those that need our help, attention, and care. It is remarkable that we are at 2 years. So, well, happy anniversary. Everybody put in a woohoo to chat. There you go. There you go. I want to see all 170 of you guys. There you go. There you go. And we're going to keep coming. We've got some great talks coming up. The artist next week, Corinne, is remarkable. She is going to show how an anatomist artist can help take you through the learning of anatomy and physiology by way of art. And it's going to be absolutely remarkable. She's going to draw artwork for us online in real time. And I think you're going to just thoroughly enjoy yourself. Later in the month, we will have the former chairman of the admissions committee at UT Southwestern, Dr. Burns, who's a really good friend of mine. And gosh almighty, he's a neuropathologist, which is what he's going to talk about. But he's going to have a lot of observations about preparation for a career in medicine, whether it's medical school, nursing practitioner, PA, and so on. So we want to thank you for coming. It means a great deal to us. We're absorbing the cost of virtual shadowing, which is not insignificant. And so when you go to take the exam, you have an opportunity to give us $1, not $100, but give what you can. It would be appreciated. It goes directly into, Zoom for $1,000, which we have, is a $2,000 a year thing. And the GoDaddy website is almost $2,000. So, you know, these costs add up. So we do have some nonprofit support, but anyway, we would appreciate whatever you can do. So Rohit, we have a wonderful speaker tonight. And would you please take us through who is going to be just exciting us tonight, and so that she can join the 180 kids that are already in the waiting room right now.
Sure. So tonight's speaker is Dr. Tamara McGregor. She's an associate professor at UT Southwestern, specializing in palliative care. She also has over 5 years of experience in private practice and has served for over 20 years as the hospice medical director. Everyone, please welcome Dr. McGregor.
Thanks for having me. Fantastic. So I'm glad to be here. When I heard about this not too long ago, I thought, well, this sounds like a pretty cool thing to do. I work a lot with medical students and pre-medical students over the years, and so very happy to just continue the tradition and want to talk to you about some of the stuff that I love to do. Okay, so thank you. A little bit of an outline. I'll talk a little bit about me. I get uncomfortable. You won't be able to tell because I talk a lot anyway, but after a little while I get tired of hearing about me. So I'll release you pretty quickly to talk about the other stuff. I'll talk about a little bit how I got here, and how, who, what, where, and why. Threw in a couple of cases, actual cases of patients that I've seen. I have a day in the life of one of my clinics last week, and we have details about family medicine as a specialty, details about palliative care as a specialty, and then I'll answer any questions you have. So, boy, I have all these words. Hang on. I'm getting these messages and I have a small screen working out here, so let me get rid of that. So grew up in Texas. You could probably tell from my accent. I wasn't born here, born in Kentucky, but grew up in Mineral Wells, which is about an hour and a half west of here. I still remember the childhood doctors that I had. When we lived in Kentucky, we had a Dr. Bickle, and we always remember Dr. Bickle because we called him Dr. Pickle. And he was an old guy, and we left Kentucky when I was 6, but I remember Dr. Bickle because we thought his name was Dr. Pickle, and he was very kind and sweet. He would give you a lollipop. Dr. Addy was a doctor we had when we moved to Cisco, Texas, where we lived for 2 years. And Dr. Addy will never forget because he actually gave ice cream prescriptions. Which to this day I associate with love and comfort. And I can't keep it in the house because I can't not eat it. So, but Dr. Addy used to, when you got shots, he would hand you literally for a prescription that you could take to the soda fountain downtown, which in Cisco they still did, and you could get a free ice cream cone.
That's terrific.
When I first went into practice, I tried to do that. There was a Dairy Queen not far from my office, and they thought I was insane, and they didn't take my idea. And so I didn't get to do ice cream prescriptions, but I still often recommend ice cream after difficult procedures, or just go home and take care of yourself. I'm, as with everybody else, my favorite TV shows were always medical as a kid. Now you guys are way too young, but Dr. Fowler is not to know who Marcus Welby is. Marcus Welby was based on an actual family physician, or they were called GPs at the time. Black and white, twinkly eye, twinkle in his eye, knew everybody, always sat down, was caring, would put a hand on the shoulder. He always had sage advice. He always got the diagnosis. He's always appropriately concerned. That was my favorite show. And
I watched it in the 1970s as they came out. But I have to tell you, Tamara, that I quit watching it when one day he put a chest x-ray upside down.
Yes. Well, I didn't know that at the time. He was in the 70s for me, and I would fight with my brother and sister because they always wanted to watch Star Trek, which I now like more now than I did during then, because we fought over me watching either Marcus Welby, and then Emergency Room was one that came after that. And there was St. Elsewhere, then there was ER, watched all of those. Scrubs, I still think, is one of the best medical TV shows. And they did a really fantastic job about end-of-life care, actually, despite being funny. I never really got into Grey's Anatomy. I didn't really relate. I think those people are having a lot more sex than we had in medical school and in residency. So I just didn't relate. But, you know, I didn't mind looking at Dr. McDreamy. I was a high school senior in biology, and we took a field trip, and which was very amazing. I was very interested in science already, and had this obsession with doctors, and so I'm the only doctor wannabe in my family at that time. And we took a field trip with everybody's favorite teacher, and we went down and we spent a day at NASA, which was fine. We spent a day at Galveston, and we got to tour the anatomy lab. So we went up in Big Red, and we went into the anatomy lab. I saw cadavers, and I thought, if I can watch this without being grossed out, I might could do medicine. The last day we spent watching open heart surgery, and so we got to see an aortic valve replacement. We were in the loft above. You could barely see around all the lights, but it was just quite shocking. The guy's completely covered in iodine. He had he had a 4-vessel cabbage, so bypass graft, 4 vessels, and an aortic valve replacement. And I was just transfixed. I just watched. There was me and one other guy. And we stood the whole time. Everybody else was sleeping on the floor. We stood for 5 hours watching this procedure. I was just couldn't believe what was going on down there. And later, that same physician did surgery on my aunt and did cabbage on her about 10 years after I had seen all of this. So it was pretty cool to have seen the guy who fixed my aunt. So that was a small world kind of deal. Anyway, that really solidified my desire to pursue medicine. I was a bio major at Tarleton State, which is in Stephenville, small town from here. And I was pre-med all the way. Got my bachelor's degree in 3.5 years. But a lot of my friends weren't getting into medical school, and I got cold feet. I started thinking, well, I don't know if I can do that. I don't know if I can get in. So I did some research with one of my favorite professors, and my mom is an English professor. And so I thought, well, I love teaching. I had been teaching in college already. And so I kind of bailed on the apply for medical school part. So got into SMU for biology and went there following my spring of 85, actually, and enjoyed my time at SMU. I worked 2 years there, but it was about 2 weeks of research that told me I should have gone to medical school. So I got there, it's like, oh, this is, I was doing parasitology and cutting up little worms, and looking at their adrenal glands and oh my God, cutting up mice that were infected with worms and looking at their adrenal glands on electron microscope, and 2 years of in the dark made me study for the MCAT, take the MCAT, did okay, and happily got in, luckily got in. This bench research was not the thing for me. Got into UT Southwestern and had a good time. The first 2 years were pretty, I would say pretty stark, because it was all how well you took tests. We all knew everybody's, they posted our grades on the wall with our social security numbers, full social security numbers on the wall. And it was not pass fail. And so before it was over, you knew everybody's last four. And my roommate, who was like 5'9" model, always scored easily 20 points better than everybody else I knew, but she was the most anxious. And so she would see my grade, I'd see hers, and I just felt awful. By the time I got to third year, it turned out that I wasn't too bad at talking. And so while I wasn't that great at test taking, I was pretty good at seeing patients, taking care of patients, and doing the clinical stuff. And so actually my grades came way up during clerkships, and which is always brings hope to me. And I bring hope to anybody else that's doing your first 2 years of medical school, because it's pretty humbling. I used to think I was smart until I got into medical school. And then I thought, geez, where did these people come from? Did my residency at John Peter Smith in Fort Worth. It's really a very high quality family medicine residency. It is not the only game in town. UT Southwestern, where I work, has a fantastic family medicine residency as well. But I had a great time at Peter Smith. Next, way too many pictures here. So I got married after my intern year. My husband up there did 2 residencies and 2 fellowships. We met when he was a neurology resident. So it was the best thing to happen at the Dallas VA. I met him my 4th year. We got married after my intern year, and with the residency, graduated in 94. I graduated at the end of June. I took the board exam a week later, and I had my first son a week after that, and had contractions during the board. But there were 1,000 people in that room all taking their board exam. So I thought, if I'm going to have an event, this is the right place to have it, because there's at least one person who could deliver. So made it to the hospital, no problems. Had David, and then had my daughter 2 years later, Rachel.
You weren't distracting the other students by moaning during the exam, were you?
No, I was not. I was not labor breathing or anything like that. I had made the suggestion that we walk down the street to Chewy's. There was a downtown Chewy's at the time, and it was 100 degrees, and that was just stupid. To
Great
be
story.
9 months pregnant and walking to Chewy's, so that was pretty dumb. But went into practice. I actually joined a practice with one of my residency friends. So in my class at John Peter Smith, we had 25 residents. That was 20 men and 5 women. So it was pretty much a boys' club. Two of the girls in my class had babies during residency. I was pregnant during my third year, big pregnant, big carpal tunnel swollen pregnant during my third year. But I managed to finish residency. Nobody had to make up for me. So that was pretty cool. But it went into practice a few months later, and she and I split the job. So her husband was an OB-GYN, and so it was a 6-man practice. So we went in as one person. So it was really cool. So I worked 3 days a week. She worked 3 days a week. We did every 12th day call, every 12th weekend. And so we kind of covered for each other. We had a little sign we put on the door. It was a little cow. So when we were using the breast pump, nobody would come in. And so we had competing breast races during lunch break. And then we saw our patients. And I covered her patients when she was gone, and she covered mine. So she had a baby and I had a baby, and then she had another baby and I had another baby. And then she moved, and then suddenly it was 1 in 6, and I had a whole lot more call and a lot more clinical. Right after my daughter was born, I was realizing that I was not a fast doctor. Okay, I'm not fast, and now 30 years later, I'm still not fast. I would never get along in the ER. I would do a fantastic, full-on, great medical workup, and Dr. Fowler would have to shoot me to make me leave. And so I realized right away that I could not see many, many, many patients. I still had the mentality that if they're in front of me, I should give them great care. I should listen to everything. I should take care of it. It's almost as if they're on my stage. This is the only time I'm ever going to see them. I want to be the best doctor they could see. And
as opposed to my world, where in my treatment pod, we'll have 20 patients at a time, some quite sick, some medium, phones ringing all the time, people talking too loud, and we're doing, plus the residents and students are there. So we've got a lot of balls in the air.
Oh, it's nuts. And my head is off. I've worked in a lot of ERs, and it's just, my problem with emergency medicine is that the people that came back, the people that I saw again, usually were the ones I didn't fix, and they were generally not happy to see me. And the feeling was mutual. In family medicine, they want to come back. So I send them away and I tell them to come back, and they come back. And I get to see what happened. And so it was like in ER, it was like never knowing the actual end of the book. I like the story and I like to know what happened. And so I really like the follow-up, and I like the continuity of family medicine.
Hey, we have a quick question. Is that an Elvis impersonator there?
Yes, it is. That was our 10th anniversary. So our 10th anniversary, we went to Las Vegas, speaking of Las Vegas, and we took the kids who did not understand that this was a joke. And we went and we dressed them up, and they did not smile at all until Elvis's third song, which was Hunk of Burning Love. And then I got a small smile from Rachel. And we asked David what he thought about it. He was 8 at the time. And he said, well, that was about the dumbest thing I've ever seen. So that was a good response for a 6 and an 8-year-old. My daughter thought it was pretty, and he was funny. And my son thought this was idiotic. So that's about right. But yeah, that was our 10-year reunion anniversary. So anyway, in private practice, I started realizing that I was working really hard, and I wasn't making a lot of money, but I was working for a practice. And I heard about, I had a patient. And so the first hospice patient I ever had was this wonderful man who came in with a cough. I was the doc on call. I had about 30 people scheduled that day. And so this was about the third patient of the day. It was very shortly after just starting practice. So David was very young. I was about a year. And this patient came in and he had this terrible cough. And he was a longtime smoker, and he and his wife had just moved here from Minnesota. They had no other family. And I was in an office where you could take a chest x-ray. And so I listened to his left chest, and it sounds distant, like you'd see here with COPD, and some wheezes. And on the right side, there's decreased breath sounds. It sounded like a septic tank. It was wet, it was gurgly, it was decreased. And I thought, oh, this is not good. So this was the day before Thanksgiving. I got a chest x-ray. I gave I gave the next 2 patients to one of my partners, because I thought this is going to take a while, because this might be bad. And sure enough, when the x-ray came off the machine, it was a softball sized mass in his right chest. And so I'd known him 20 minutes, and I had to sit down with him and his wife on the day before Thanksgiving, my first 2 months in practice, to say, this looks like a cancer. It might be a fungus infection, but I'm worried with their 60-pack year history that this may be cancer. And so I called my friendly neighborhood pulmonologist upstairs and asked him, you know, do you want a CT or do you want to set him up for a bronch or whatever? And sure it was cancer. And so he was really, and I remember thinking to myself, I went 4 years at medical school. I did 3 years at John Peter Smith. And I never was the one that found the first cancer. I was never the one who found the cancer, told him about it, set him off in motion for treatment. And I was glad that I did a few things. And so I thought, wow, first of all, I'm glad I passed a couple of patients over. Second, I'm really glad I got that chest x-ray and didn't blow it off. Third, I sat down to tell them about this terrible news. And I brought the x-ray with me so I could explain it and then show them the physical finding on the chest x-ray, answer their questions, not be in a hurry. Try not to cry. I managed not to cry. They did. I didn't, but I cry at Folgers commercials, so that, you know, happens all the time. But that was my first cancer diagnosis. He was also my first hospice referral, because about 6 months later and 3 hospitalizations for pneumonia, he indeed was worse. And his home health nurses actually asked me to refer him to hospice. And so
I remember I went home. There's actually another anniversary. I went home to practice medicine in 1980 and built and opened an urgent care center in 1982 on June the 1st. So I later left home, but the clinic is still there, called Immediate Care. Mm-hmm. And so I will celebrate tomorrow the 40th year of having opened an urgent care center. It's kind of interesting.
Wow, that's
yeah.
So that experience with that patient kind of triggered something. I'd heard of hospice in residency. We didn't have any death or dying courses in medical school. We saw one sad movie that I remember, you know, some lady got sick and died and they passed around Kleenex, and we didn't really talk a lot about death and dying in residency. We didn't talk a lot about really bad call nights or terrible experiences. And so it struck me that I knew about hospice, but I didn't know much. And so later, about 6 months after he passed, he did get hospice. He had hospice for about 2 days. So that was it's not uncommon for people who don't know what to look for. But that hospice later reminded me is nice and teachable. So in life, be considered nice and be considered teachable. Because when the hospice nurses were caring for him, they were asking me, you know, what would you like to do for his pain? And I said, well, I don't know, I haven't treated a lot of pain, shockingly. Well, what do most doctors like to do? Okay, well, let's try this. And I kept up with them, and I did not give him over to another physician. He had an oncologist, but there was nothing else they could do. And so I kept in the relationship despite the fact that I couldn't fix what he had. And it was meaningful. He passed. And a few months after that, the hospice that took care of him remembered me as nice and teachable, and they needed a medical director. So I had 2 small children. I had 1 3/4-time job. And then I took a hospice job because it gave me regular salary. So I got all of $500 a month to take call 24/7 for this hospice. And to do team meetings every other week. But that $500 a month was consistent, and I could pay the nanny with it. And it was the thing that we needed, and it was a very consistent job. What I didn't know is I would fall in love with it, and that kind of medicine became very, very meaningful to me. And it really changed my practice. I thought, well, this is kind of cool. This is mushy. I think I can do this. I had no idea what it was going to do. Once my husband finished his neurology residency, then his radiology residency, then his neuroradiology fellowship, and then his interventional neuroradiology fellowship, we decided to move to Dallas. And so we moved to Dallas. I got a job at St. Paul, which is gone, and joined a family practice there, worked there about 2 years. 2 years of hard work in a private practice later. Again, struggling with time, struggling with talking too much. I got offered an academic position, I guess because that's all I do is talk, and you get paid to talk if you go into academics. I joined in 2000, worked there for 2 years, and then the UT Southwestern Family Medicine program absorbed the St. Paul program, and so I was off to the races. Now, I only took the academic job on the agreement that I would continue to do my hospice job. and I would continue to see my own patients. And so I did not give up my patient practice. About 60% of them followed me from Fort Worth to Dallas, which was insane. And it's still about half of the patients I see now are still patients that I've seen since Fort Worth, which is just crazy. I worked for that hospice for a little while, and again through into the residency program. Then I took another job with a local hospice and worked for them. It was a hospice that took care of adults and children. Took call for them for 18 years. Saw patients every other week, did house calls every other week, raised 2 kids, started a palliative program at University Hospital, which is on the next page. So it's sort of that period of time. Dr. Fowler can probably relate. You guys can probably relate. All the things you're doing now, which just seems superhuman. You look back at it and you don't know how you did it. And I don't know how I did it.
Yeah, I did 23 years in private practice, and then I retired at the age of 47 and decided to do something nice and quiet. So I came to Parkland Hospital. And I joined in 2001. So I'm a 21 year, you're a 20 year.
Yeah. We came on around about the same time. So so from 2002 to present, I've been in academics. I've been a family medicine faculty at UT Southwestern, still seeing my own patients. They invited me to be a college's mentor, which is like Hogwarts at UT Southwestern. So I got to be a mentor starting in 2008. These are pictures of my various mentor groups I've had. So since we've been doing it since 2008, however many that is, I get a new group every other year. And so I have graduated multiple classes of my students. And the coolest thing I love about doing the mentoring is that I get these guys on day 1 of medical school. And I see them all the way through to day last. So I teach them how to do an ear exam. I teach them how to do a heart exam. Their first belly might have been me. It's just something super cool. I'm very maternal about it. I want to give them great teaching from day 1 to day last, and I get to cloak them and graduate them. And so it's just the most wonderful thing. I love just taking them from brand new babies, first year, all the way up through. Hear from them later as they finish their residencies, they have their kids, they start their practices, they cure cancer. I mean, it's just incredible to watch it. So it's a wonderful, very maternal experience. So I absolutely love mentoring and colleges. A little bit more work, we decided that we needed, it came about that the UT Southwestern was about to get National Cancer Institute approved, which was very exciting. And the day before they announced it, they realized that they did not have palliative care at UT Southwestern. And so Elizabeth Polk, who I know Ray knows well, is amazing palliative care queen at Parkland. And she called me and she said, hey, can you and this oncologist go start a pally service at university hospitals? And I said, and so I did. So I did that, and I did hospice consults for about 7-8 years, hospital consults for Pally. Clinic still, family medicine clinic still, hospice medical director still, kids still, marriage still, parents, siblings, all that stuff. So I don't know, it was pretty manic how much I did during that time. Loved it. Come about 2017, I got a new boss here in family medicine who said, God, your eyes are going in 2 different directions. You don't look well. What can I do to help you? And so I went from 40% internal medicine, which was all my palliative job, to 20% internal medicine, which meant I could no longer do the hospital service, which was what I needed. Because as a family physician, if my patients are in the hospital, I've screwed up somehow. Okay. I didn't prevent that cancer. I didn't keep them from having that heart attack. I didn't, keep them from getting that DVT. So when my patients are in the hospital, I feel like I should have done something better. So to live in a hospital and work in a hospital just gave me the heebie-jeebies. So I was very happy to get out of it. I still do hospital work, but nothing like I was doing at that time. So started doing more teaching. I got a kind of leadership position with now the pre-doc or the early medical student teaching. So the pre-clerkship is the first 18 months at UT Southwestern, and then clerkship is the last 2.5 years at medical school. And so I started working with the family medicine interest group, still doing that. I'm helped with the family medicine clerkship, so I'm the assistant director there. We started a family medicine sub-internship. Sub-internship is where, as a 4th year medical student, you work just the same as an intern. And so the only thing you can't do is sign your own orders, but you work on the medicine service, family medicine service, you admit patients, you examine them, you do procedures on them, you order labs, you do everything for them, but you just have to have a senior sign for you. We love our sub-I. We have locations here at Parkland and also at Presbyterian. Over the last couple of years, we've partnered with THD Presby. And so I love the student work that I do. We do lots of procedures workshops.
Absolutely. Dan Symptom is a good friend of mine in your program there. And he spoke to us a few months ago and gave a wonderful talk.
Yeah, he's the bomb. I helped hire him. So, okay. All right. So way too much about me. All right. So there's the, oh God, she won't stop talking emoji. There's the I can't listen anymore. And here's the toothpicks to keep your eyes open. So one thing that was very true about me all through college, grad school, medical school, residency, early childhood of my children, and up to now is that I cannot stay awake. If I am tired, I am dead out, like narcolepsy, only it's not diagnosed. And so I'm going to honor you that you've been hearing my voice for a long time about me. This is too much about me. I'll answer questions as we go. But
we are totally cool, thoroughly enjoying this. If you need to get up and walk around for a minute, please do. But we are loving what you're doing there.
I think I'm getting a DVT. So, all right. So the toothpicks under Tom's eyes, so stay awake. So anyway, next slide. So since Dan talked to you guys about family medicine, I'll probably do less about family. I'll rave about it, but I won't go into the nuts and bolts unless anybody wants to hear more about it. Well, love family medicine. It's all I ever wanted to do. I went into medical school thinking that I wanted to be a family doc, and it was the specialty to beat. And so after the clerkship year, for us, it was the third year. I loved the kids. I loved the moms. I loved the grandmas. I loved the granddads. I loved the grumpy dads who didn't want to come to the doctor. I loved the adolescents who wouldn't talk to you, but they just smirk and look at they didn't have phones, but they were looking at their Game Boys, So I loved all of those ages. Didn't love standing up in the OR, but I really liked the rapport. They had good music in the OR. And so we played Name That Tune in the OR. And there were things about ER that I liked, but I really liked the continuity. So I love family medicine. And I will answer any question you have about that. Again, the residencies are usually 3 years in length. There are some that have 4. And obviously, if you're going to be doing obstetrics and gynecology, you're going to be doing C-sections, you need more surgical experience. So you should not do those things having only 3 years of family medicine residency and other surgical subspecialties. We cover all ages and all stages. Basically, we cover everything that everybody could have. Now, we spend more time on things that are in our scope of practice and a little less time in things that are in specialty scopes of practice, so that we have a good familiarity with it. So I can explain to someone what their colonoscopy is going to be like, but I don't need to drive that scope, okay? I can tell them and I can do their dermatology because everybody that walks into my office has skin, and after 30 years of doing this, I know skin. But if they have something that looks like melanoma, I am trucking their butt straight to the specialist and getting that taken care of. So for me, living in Dallas and the standard of care being there's a perfectly great pediatric orthopedist 7 blocks away, there's no way I need to be really good at casting and splinting unless I live in the middle of nowhere, Texas, where I'm the only doc for 200 miles. So I like being in an urban setting.
Back home from 1980 to into the 90s, to raise money also, like you did your gig on the side, I would go over and do what's called institutional medicine, which is I was the doc for the jail.
Oh, yep.
And
I did a little moonlighting at Peter Smith for about 6 months at the Tarrant County Jail.
Oh, yeah.
Dreadful.
So I would go in there to the little office they gave me, and the inmates would come in, and I'd examine them and write some scripts.
One problem. Yep.
Yeah, exactly. And so there was this big fella came in, big tough guy. And I said, and I always asked, well, by the way, why are you in here? And so I saw this fellow who had a backache, and I was writing a prescription. And I finally said, so by the way, why are you in here? And he said, they said I did armed robbery. I said, really? How many times? He said, 14.
That was some kind of rumor he's got going. See, I'm sure he was framed. I'm sure
He was framed.
it was
Okay,
the other guy. It wasn't him. It was his evil twin. So
Did you ever move an ultrasound into your office?
I did not. I did not. They're doing a lot of ultrasound in our department. I'm still sort of cogitating about whether or not I need to learn it.
I know.
I'm almost 60. I don't think I'm going to get good at it.
Yeah, I wanted to buy one of these new devices called a Butterfly IQ, which fits in your pocket.
Yeah, our department is doing a lot of point of care ultrasound.
Yeah, and because I've got my stethoscope and I can listen well, and the hospital doesn't mess with me on my stethoscope.
Yeah.
And I said, fine, I just want to have the ultrasound in my pocket so I can whip the thing out and just look and teach myself.
Sure.
And the hospital actually said, you can't do that.
Yeah.
Because it's got to be uploaded into the medical record and so forth.
Yep,
and I just said, well,
too much liability. Yeah.
Too much.
I'm not real good with 3D skills. I'm good with dollars, but I'm good with numbers, but not dollars. And I'm good with procedures, but not 3D screens and, orientation on sonos and things like that. So I think I'm going to let that skill go. All right. All right. Just a quick, this is a summary of an actual clinic day. Now, this is actually kind of fun. So this was a day last week. Now, there's not a bunch of patients, but they were action-packed and they were all pretty high level. Family medicine, if you're not seeing kids, and I see kids, but I see my own patients are now old as I am, and so they've got, chronic health problems. So my first patient of the morning was this lovely man who had high blood pressure and hyperlipidemia, stroke history, coronary artery disease, chronic knee pain, multiple traumas, osteoarthritis, depression, anxiety. Lots of wild beliefs about a lot of things, very strong opinions about life. I saw him first. I've been seeing him for about 12 years, which seems amazing. Second patient I saw in the morning was one of my all-time favorite patients, which my husband laughs because I say, oh, I saw my favorite patient today. And he goes, all of your patients are your favorite patients. And I would argue that's not exactly true, but yeah, I do really like my patients. And so my second one, 51-year-old female with type 2 diabetes, I met her 22 years ago. Oh my goodness. So I had barely just moved to Dallas. And she brought me her son who was not feeling well. And we diagnosed his type 1 diabetes. And while he was getting treatment for his DKA with his type 1 diabetes, we found that she had type 2 diabetes. And so I do remember all those details, except she has fully told them again later. But I was seeing her the other day for follow-up on her diabetes and set her up for some, screening things like mammograms and colonoscopies. The fun thing over there in the corner, my patient, this patient, in 2019, called me and said, Dr. Mack, you got to be in this movie with me. And I said, oh, honey, I don't act. I don't do movies. And she goes, I said, I watch movies. I don't do movies. And she said, no, you don't understand. It's called A Touch of Sugar. It's about type 2 diabetics. And I said, well, why do you want me in your movie? And she goes, because they wanted to see somebody who had a long time relationship with their primary care doctor. And none of the other patients had a doctor they could ask. And I said, well, A, that's kind of sad, but B, okay, what do I got to do? So we sort of snuck the film crew into a makeshift office. I didn't quite have permission from the university until after to do this, because she asked me on a Tuesday and it had to be filmed on a Thursday. So basically they interviewed me about my care of her, and they interviewed her about my care of her and all that stuff. And then a few months passed and she calls me and she's, Dr. Mack, guess who is narrating our movie? And I said, well, I don't know. And she goes, Viola Davis. And I said, you're joking, Viola Davis, like the famous Viola Davis? And she goes, yes. And I said, why? And she said, because her grandma lost her foot to diabetes, and she has sisters with diabetes, and she's pre-diabetic, and she heard about the project and she's in. And I was like, well, holy cow. So she narrates the thing, and I hear about it a few months later, and there's a red carpet event at the Tribeca Film Festival in New York City in 2019 of A Touch of Sugar. And and they wanted me on the panel. So I catch a plane, go up there, try to find a dress I could stand. I still don't like the one I found. Went to the red carpet event, got to meet Ms. Davis, and then got to watch the screening of the movie. I had about 10 seconds on the screen, so my 10 seconds of fame were there. And then I was on this panel discussion, and it was just out of body. There was Hulu and Amazon and HBO and a couple of them, and there were just movie screens and all this light and everything. But it was super cool, and it's actually out there in the stratosphere. I've had a couple of people tell me they've seen it on cable. So it was my 10 seconds of greatness. But that's because of my second patient of that morning, just because she knew me well enough to ask me, and I was dumb enough to say yes. The third and fourth patients I've been seeing for 26 years, so longer than I have known my daughter, and almost as long as I knew my son. So they are couples that they are my age, and they got married. They met each other and started dating at age 15. So they're high school sweethearts, and it's just sweet as can be. And I've known them all these years since my Fort Worth practice. Both are diabetic, both have hypertension, both have hyperlipidemia and osteoarthritis. He has had an MI and has coronary stents, and he has positive ANA and really bad sort of rheumatologic joint problems. She was in a head-on collision early in our practice life and has chronic pain, knee, shoulder, joint, back. They came in for follow-up on their labs, and I'm still seeing them. So I see them every few months, and they come over from Fort Worth to here, and I still can't explain it. My fifth patient of the morning was a 21-year-old, gravida 0, para 0, so she's had no children, came to the office for her first PAP. Her mother, who is also my patient for about 19 years, and her brother, who I've known since he was born, was also my patient, came in. Now he stepped into the waiting room, but mom stayed in the room while I did her first PAP. And we got to talk about prevention, and she's already had on her full HPV vaccine series. And so that was kind of cool to see her. And then the last one was a patient, a lady who I've seen for 12 years, no, how many years? 22 years, oh my gosh, who used to work with me at hospice. So that first hospice second hospice I worked with, she was a hospice care aide, and just is the sweetest person in the whole world. The sweetest voice. She's beat cancer. She has pretty terrific joint disease. She actually had an accident. She was coming out of a grocery store, and a car jumped a curb and injured her. And so her chronic pain is related to this injury that she had. But she's the most positive, most wonderful person. And she didn't have a ride that day, and so we did a televisit. So my favorite patients. And I have a bunch of them. Have a case. I'll stop for a second. Anybody have questions so far? I guess, Rohit, you're going to tell me if there's anything on the chat.
Yeah, we have a couple of questions so far. I can ask one or two right now.
Okay.
So one question that we got is, how do physicians or providers gauge how long a patient has left to live, given a condition with no curative treatment?
That is a fantastic question. I'm going to get into sort of Palliative and hospice realm shortly. There are some prognostic tools. At first, before we had the tools, it was sort of the best guess. And so it's still a pretty good guess, because as smart as I am, God knows maybe, but he's not talking to me. So, you kind of have to go based on your experience. But there are some prognostic indicators. I have to think about the tool. There's one called the SPICT, which is a tool. And that is a palliative care tool, and that's really good. Dang, I wish I could remember the other one. I'll have to think about it. I may have to text it back to you. There's some good prognostic things. You can there's one called, I think it's called prognosis.org or prognosis.com. ePrognosis. I think it's ePrognosis. And you can put in information about the patient, and then it will give you sort of ballpark ideas. The one I can't remember is the one that shows the predictability of rehospitalization. So your patient comes in and they have multiple problems, and multiple problems times how long times what complications times whatever gives you a best guess of whether or not they're likely to come straight back. And So in life and in hospital medicine, the only thing worse than admitting a very complicated patient is sending them home and having them come straight back. We call those bounce backs. That is Dr. Fowler's entire existence. So people that get sent out of the hospital too quickly come through Dr. Fowler's ER. So bounce backs are really, it's hard because you have to admit your failure. You didn't take care of them. You didn't fix what they had, and they're right here again. So, but that's a great question for prognostic. Yeah, I'll try and think of that tool, but just look it up. Prognosis. ePrognosis, I think, is a calculator you can look up. Do not show this to patients. Do not use it to tell your grandma how she's doing. This is the kind of thing that makes you think. It might get you to get more information. You might want to make sooner interventions. These things are not fated. If you see someone is very much at risk, the goal is not to just funnel them onto hospice. The goal, if you can, is to help them go the other direction. So, but knowledge is power, and knowledge and power of that knowledge help you do a better job for your very sick patients, but also to help guide them. Because if they are really third rounding home, they're really quite ill and they're nearing the end of their life, and they need someone to be honest. Do be comforted in the fact that you will not have to be that person and should not be that person prognosticating your patients as a pre-med student, as a med student, as an intern. These are things that have to come with some experience. You get to always defer to your senior or to your attending, but bring it up. And you want to talk about those things because that shows you're paying attention, and you might get better care for that person, and you might turn the corner for them, or you might help them avoid a tragic, bad, long ICU death. So, but that's a great question.
Thank you for sharing. I'll just ask one more question for now. Can you touch on how you handled being a mother while trying to pursue your career? How do you balance between being a mother and practicing medicine?
I was very fortunate. When my parents are fantastic and they've worked my whole life. My mother raised the three, my brother and sister and I, for 10 years. And after about 10 years, she got us into school age and into school. And then she said, I want to get my degree. And not only do I want my bachelor's, but I want my master's, and I want to teach, and I want to work as a professor. And she, did something that they weren't really doing in the early 70s. And so she was kind of a pioneer in my book, definitely influenced my model, which is you can do a lot of things and don't sacrifice, perfection for really, really good. So if you can't get perfection, be really, really good. But she taught me early when I had kids, because I knew I wanted to have kids. I knew I wanted to be a doctor, and I knew I wanted to have a family. And I decided that I would try it anyway. And she helped me know that when your babies are babies, as long as they have a consistent, loving caregiver to care for them, feed them, comfort them, play with them, talk to them, read to them while you're at work, then they're going to be okay. They don't know anything else. So all we knew for most of our lives is that mom worked and she came home, and whoever got home first would start dinner. And we weren't scarred for life. I had a good model of a very wonderful set of parents, and so working did not harm us in any way. But she taught me that, and so I shared a nanny for the first 2 years with one of my friends, and so I would take David to the nanny, and he had a sitter there when we shared it with another kid. And then when Lee finished his training, my husband finished his training, and we had a little bit more money, then we hired a nanny. She did not live with us, but she was our nanny for 17 years. And so my advice on getting childcare, she did not live with us, like I said, is treat them well. They are your family. They enable you to be a good mom and a good dad. And they enable you to have a wonderful, well-adjusted kid who's safe and can be in the comfort of their own house, etc. And treat them like family. And so very quickly, we realized how wonderful she was. And so we got her health insurance. And when she needed to get surgery, we gave her time off to get surgery. And she really, literally, for all those years, had more vacation than either of us. Because when she needed to go see her family, that was key. And we would scramble and take care of the kids. I would do more and he would do more whenever Norma wasn't with us. But we could not have done it without such a wonderful caregiver. When they were older, and they needed me there. I actually was part-time for a little while. So instead of working every day of the week, I worked 3 days a week. And then you start figuring out as a parent, what things can you go to that gives you credit for having been there? So I found out our school district allowed parents to help with the cafeteria duty or teacher workroom or things like that. And so there are 3 fifth Thursdays in a year. So guess when I did cafeteria duty? It was the 5th Thursday. So, and you don't tell them that you're going to be there. And so they come, to get their burger and their, potato chips and ranch dressing. And there you are. Or you do stuff after hours. So you're not, I could never be room mom. I just had to say, I'm never going to be room mom. I'm also not going to be home at 2 o'clock in the afternoon. I'm going to have full days. I'll take them to school, but Norma would pick them up. And then we would converge around 6 or 6:30. And then I'd had them for, we'd have them for the rest of the night. And so it was as normal as it could be with 2 doctors and a nanny, but getting a consistent person and then setting that priority that they're going to get your love and your care and your attention. I think the mistakes I made were probably that when I started working more, I didn't realize that it was probably impacting them because I was so tired, just so tired. So, probably a little more attention to wellness and a little less attention to, creating a service and starting a whole, specialty. But you can do it. And just, you got I have some advice at the end of this, and you can morph. All right. Just love yourself and accept yourself as human, and you're going to do the best, and your kids are going to know it.
Thank you for sharing that advice. We have a few more questions, but I'll save them for now for the Q&A later.
Yeah, you can tell there's a lot of words come from this mouth. All right, so the first case is a Miss L. Miss L, I took care of for, 12, 13 years. She came to me about now 15 years ago. Female with hypertension, COPD from a long smoking history. Previous alcohol, had quit long before I knew her. Hyperlipidemia, terrible arthritis. She had a very rough life. On the domestic abuse, a couple of serious car accidents. She had been worked on her feet for many years. So she had just really terrible joints. I mean, poop for joints. They were terrible joints. And so she had a lot of really bad joint disease and a lot of chronic pain. Started seeing her in 2008. And on that day, she brought also her mom, who had a really bad stroke. And so she had hemiparesis, tremor, hypothyroidism, hypertension, COPD also, a lot of depression, bad teeth, bad bowels. And I also became her PCP. So I took care of both of them for several years. I did chronic disease management for both. Interestingly, they didn't usually come together. They had some estrangement in the family. So the daughters didn't always get along, and the daughters and the mom didn't always get along. So I didn't always see them together, which is kind of thankful because I could never get in and out of there in less than an hour. But I did it the best wellness I could for them. I, did cancer screening and all of that stuff. And so that's Miss L. She was very challenging, very sweet, but had a really tough life and had a lot of really complicated problems. She took her meds. She did what I asked. Started having chronic pain issues. She took NSAIDs for a long time for her arthritis, and then had this really bad knee replacement that failed, and then it failed again. And then she had a left knee replacement, and it also didn't do well. She had very poor healing. In a year and a half's time, she had neck surgery, back surgery, bilateral carpal tunnel surgeries, and 2 knee replacements. And so that's really a lot of surgery to put yourself through. I did not recommend all of that, but I think she nailed some good insurance, and she said, well, I haven't taken care of myself, so now's the time. But unfortunately, she developed a GI bleed, probably secondary to the NSAIDs, and had to stop taking that. And so it was at that point in about 2015 that I had to put her on low-dose opioid for her just destroyed joints. She could not function without low-dose hydrocodone. And so that, became part of what I took care of. She struggled to quit smoking despite counseling, medications, and treated her COPD. Very long story made not very short, was what happened to her mom. Miss M was her mom. She continued to have TIAs, transient ischemic attacks, and her stroke sequelae from her original really bad stroke got worse. She went from being able to walk with help and being somewhat independent at home to being completely dependent on a wheelchair only, and couldn't even transfer from the wheelchair. She did have Medicaid and actually qualified for a caregiver, who was very helpful, who would bring her to her appointments with me. I saw her about every 4 weeks because she was so complicated. And I never got in and out of there in less than an hour. She lost her vision and had complications from that. She got more and more dependent and more disabled. But she was sweet. She would grab me. She actually saw my husband as well, and we teased her. He was seeing her for she had a small aneurysm that was not the reason for her stroke, and so she's talking to him, and he said, "Well, tell me who your primary care doctor is." And she goes, "Oh, she's so sweet." And he knew that she was my patient. And he said, "Oh, what's her name?" "Oh, Dr. Mack." And he goes, "Well, I think she's sweet too. She's my wife." And so we had that little joke for all these years. Now, the sad and worst part, she got COVID before the vaccinations and got super sick. And despite the fact that she had been pretty clear with me for years that she did not want to have CPR and she did not want to be in an ICU, because of the time and because of how quickly she got sick, and once she was in, she couldn't really leave and no one could visit her. And we couldn't necessarily, at that time, nobody was vaccinated, so you couldn't really bring her home for hospice. Plus she was in respiratory fragility. She could not breathe. And so we really couldn't get her that home hospice death. There was a lot of toil in the family, a lot of turmoil. They fought over what she wanted. She could not speak. But she had a complicated ICU death, which makes me very sad still, because I know that the conversations we'd had over the years is this really wasn't what she wanted, but nobody saw COVID coming. That was just beat us all. But I gave support to her daughters and grandkids. Whew, all right, that's pretty dark. Why do I love family medicine? A million reasons. I will not name these all, okay? I will tell you that I love being able to see every type of patient. I love being able to see all ages and stages. I love movies, and every patient has a movie. Everybody's got a story, a backstory, a future, and a past, and a present, and a future. And I don't know, there's something about knowing something about this other person. It's a privilege to know them in this way. Total stranger, never met me, walks in. Not a single person in all these years has ever asked to see my diploma. They just trust. I'm wearing a white coat. They say, she must be a doctor. I'm going to tell her my most intimate secrets. And I just take that to be sacred. That's a sacred space for me. So I love it. I like talking to other specialists. I like being able to refer people who are too sick for me. I love being able to refer that person with a very specialized problem, and then I learn from it. If I send them back to their specialist for their complicated migraines and they come back to me on a new medicine, I'm going to learn from that. And then the next time I see somebody, I might try that medicine first. I like to make the specialist work just a little bit harder for their referral. So I'm not going to send you to GI with GERD without treating your GERD, all right? And then you can go to the GI specialist and get other things. But I like doing the first things first, but I love being able to refer. Patients, I like talking to, I like teaching. Every patient I see, I guess the reason why I talk so much is that I really like teaching them about their illness, because I'm trying to prevent further problems. I like seeing kids. I always say kids are the dessert of family medicine. So, middle-aged person, chronic problem, middle-aged person, chronic problem, young person, earache, mono, sore throat, adolescent, contraceptive, kid. So kids in the middle of my day are like dessert. I crawl around on the floor and make goo-goo faces and, talk about how pretty they are and teach mom about breastfeeding. And it never gets old. There's a lot of variability in family medicine, and you can do it anywhere. Okay. You can do it on a boat. You could do it on a train. You could do it in a box. You could do it with a fox. You can do family medicine everywhere you are. You can be global. I've been on several global trips, and it's so cool to be the one that knows a lot. So I can know what to do with your diabetes. I know what to do for your rash. I know what to do for your vaginal bleeding. I know what that mass is. I mean, there's just a lot of fun having a broad training. It just makes you feel very useful. And I like that. And so I super love it. I even like the mental health component. When they come in and you think you're going to talk about diabetes and they tell you instead about their, domestic violence or their severe depression. So it never gets boring. So many reasons. I covered a lot of them, but I absolutely love family medicine. Where you can do it everywhere. Okay. I didn't enjoy jail medicine. I only did it on Wednesday mornings for about 6 months. But there's a real need for it. And, so much illness in all of these environments. And there's a lot of things you can do. I decided cruise medicine, as good as it sounded, would not be where I'd want to be. I would not to be the only physician on a cruise in the middle of the ocean. On a ship where people eat 6-7 times a day, the richest food and the most alcohol you can stuff into your body because it's covered. And then for someone to have chest pain or a heart attack in the middle of the deep blue sea. So decided cruise medicine is not something I wanted to do. I did have some friends that did it, but they did not do it for very long. So,
it's a really big deal on those cruises because the ship really doesn't want to dock. Doesn't want to go back to the port.
It costs money. Yeah.
It's huge. And so, and flying somebody off a boat is a big, expensive deal, $100,000 more to fly somebody off.
I have friends from family medicine residency that before you had to have ER fellowship, before you had to have ER training residency in emergency medicine, they would go and do ERs in the middle of nowhere, and they do 96 hours on a weekend, which is crazy. And I decided that I don't like that kind of adrenaline. Okay. I don't like the, oh my God, somebody's going to die right now kind of adrenaline. I decided that most adrenaline I wanted when the kids were growing up were good report cards. But could I do it when I had to? Yes. Could I do it if I had to? Sure. Do I want to do it on a daily basis? No, it makes me too nervous now. So none of that for me. All right. So how did I morph from just a good old fashioned family medicine practice into a family pally medical practice? And, I bet it probably started back in residency because I remember having an existential distress. We had such sick patients, so sick, never with the benefit of preventive care, terrible social situations, trauma, abuse, refugee health, just the worst poverty. And you just would see this huge discrepancy between what people needed and what could they get. And it just bothered me. It would make me sad. And these really crisis patients and these very burdensome treatments. So they'd have terrible cancer, one, and then the treatment for that terrible cancer was worse than the cancer. And so there was a lot of suffering, and you'd see a lot of suffering, and I'd feel helpless, but I couldn't help that suffering. And I didn't like that, and it bothered me. And I don't remember us having a lot of debriefing with our attendings. I don't remember our attendings saying, hey, it's okay to feel sad. Tell me if you're feeling really sad. We should talk about this. There was a lot of real machismo back in the day that you just suck it up and you don't talk about it. And that was not healthy, and that was not good. And I remember thinking there's got to be something better than this. And so when I heard about hospice, first of all, I thought it was a place. So I thought it was a nice place with nice drapes that people went to die. So I had this concept that it was about dying, but I didn't really know that it could be at home, it could be in a hospital, it could be in a nursing facility, it could be in a unit. But I did appreciate that concept that the death is inevitable and that it's natural to die. None of us is going to live forever, that I can tell. There are lectures that may seem forever, like this one, but it's not going to go on forever. This is a finite lecture. But it was great to think there is something we can do, even if we can't fix. There was a program I remember watching around the time I was thinking about doing hospice, even still as a resident, called Care Beyond Cure. And this was VHS tapes, and you had to buy them, and you check them out, and these smart people would do these conversations, these communication modules on how to talk to somebody, to tell them about their cancer and to entertain their ideas about end of life and things like that. And I just remember thinking, it was like a light went on for me. It was like saying, wow, I really, really love family medicine. This is even more. This is rich. This is a richer thing, and it's going to help me feel better by making people feel better, even if I can't fix what they have. And so it really gave me some insight, and it gave me some peace, because if you know, I didn't give that person cancer, right? But I couldn't cure it either. But I could listen to them and I could help them feel better through it. And then I could help facilitate a better end of life for them, which would give them better healing and then help their families grieve more healthily, right? And so this was just like this, I don't even know, a revelation for me to be able to kind of do that kind of care. So I love that too. And again, I don't know if at first it was more for me than for the patients. And then it was sort of a coexistence, sort of a symbiosis where I felt better because they felt better and they felt better because I helped or something. But but that's it's kind of an addictive situation. And so I really loved it. Took the medical director job again, like at first for paycheck to pay the nanny. But then because I just fell in love with it and became very passionate about what you can accomplish. I liken it to, if you call your grandma and she's not expecting you to call, okay? You are suddenly the greatest grandkid that they ever had. And they will brag to everybody they know what a wonderful grandchild they have. And if you do something extra for a patient, you call them when they're not expecting to have a call. You swing by their house on your way home because it's on the way. It's just this amazing appreciation for small things. You don't even have to do a big thing to make them appreciate it because it's out of the ordinary. It's different. So that's the whole specialty. Okay. What is palliative care? So it's an approach to making someone more comfortable. Okay. And they don't have to be dying to get it. All right. Palliative care came from hospice saying that everybody has the right to be kept comfortable in the place they want to be and have some control over the kind of treatment they receive in a very short prognostic situation. But it's been expanded. So palliative care is not limited to time. It's limited to someone with serious illness, but we can use that same concept. Listen to what they want, give them good options, help them be comfortable enough to tolerate treatment. Or if the treatment is very uncomfortable, help them understand what their choices are and communicate with them clearly and be a go-between between them and maybe their specialist if they're having trouble communicating. Primary palliative care is the thing that I'm doing a lot of now, which is I'm a palliative care physician and a family physician, but I love teaching non-palliative doctors how to do this better, because there's a statistic that I think it's like 2030 or 2035 that said for every one palliative trained boarded palliative physician in the United States, there are 26,000 palliative eligible patients. So that would be me and 26,000 patients trying to see me. So it's impossible for us to have enough palliative physicians to do every person that dies or who dies.
Yeah, Tamara, we've discussed across virtual shadowing a couple of years, Atul Gawande's amazing book, Being Mortal.
God, I listen.
And, he starts off that amazing, it's a wonderful book. Everybody on here ought to really, it's Atul Gawande, put it in the Aditya, put it in Atul Gawande, Being Mortal. That, we in this country do not, by and large, do a good job of finding out what people want at the end of their lives, by and large.
We tell them what's available and then we keep moving. This is what we're going to do. And we don't, it's not a two-way street a lot of times, and it needs to be.
And you may know of the POTS, Physician Orders for Life-Sustaining Treatment.
Of course.
Movement nationwide. Texas actually doesn't have it yet. We have a state nonprofit foundation that I serve on the board of to try to get a statute in Texas so people can write down exactly what they want together with their doctor. Don't break my sternum, CPR. I want to be at home in my bed. I want my pain controlled. I do not want an NG tube, yada, yada, yada. Right. So any comments about that along the way would be interesting.
Yeah, well, and I appreciate, I am spoiled because I'm in a state that is very, it's a bit paternalistic. So since I've been in practice, I graduated in 91 and finished residency in 94, a little bit paternalistic. So it kind of gives a lot of ability of the physician to explain things in a way, and then we can lead that patient or that family and that patient with good information. They could come to their own decisions. I will say that there are some patients who really would want to be able to say, I don't want my sternum broken, but I do want electrical shocks. I don't want IV fluids. I don't want an NG tube, but I do want IV fluids. It gets a little bit granular, like is it ketchup or mustard, onions or pickles? We're asking them to make very complex medical decisions, and that can be really overwhelming for some people. Some people are all over it. They come to me with their pulse from another state, or they come with me with 5 wishes from another state and say, these are things that are important to me. And I say, thank you. Until you've had that conversation. I wrote a conversation tool when we started doing Palliative at University Hospitals on how to get into this conversation. Ask me about my tool. It's not a good tool. It's a conversation tool. It's not validatable because it's really narrative answers, but it was a way to talk to total strangers about hard, scary stuff and get them to understand that everything doesn't always go well. I mean, I do Palli consults for patients who are contemplating transplant, heart transplant, lung transplant, kidney transplants. And so we have end of life conversations with people who are expecting to get a new organ on Tuesday. And so these are not always based in reality. They know how sick they are, but they're not thinking about dying before next Tuesday. And so I appreciate polls, but at the same time, I think there needs to be a way to ease onto it, and I think we can use it. But I think if we require people to make those sort of levels of decision, there's a shutdown. You've seen it. You tell them too much, and they shut down, and they won't make a decision because it's scary.
Yeah, one of my jobs is that I'm an EMS medical director, and actually I'm EMS chief for UT Southwestern. And it's interesting that state law in Texas is that if EMS goes out and the patient is down without a pulse, and there is no Texas EMS DNR, it is the EMS DNR present, they have to attempt resuscitation.
Unless you have a hospital DNR.
We need to fix that.
Yeah, we do. It's insane that I have to tell people, here's your paper. Don't fill it out until you're with your doctor. And then you need to make 6 copies of it. And this says, do not attempt resuscitation on me because it's not going to help me. I don't want to live that way. It's going to hurt me. I'm not going to be okay when I come back, et cetera, et cetera. And then I tell them to keep one in their glove box, one in their purse, one in their wallet, one near the door of their house, one with their doctor, one in the EMR. I mean, it's kind of crazy that we're dependent on a piece of paper with a little symbol of Texas on top so that somebody with stage 4 metastatic melanoma does not have to have CPR if he dies at home without hospice involvement. It's a nutty situation. It is.
Yeah, there's an old phrase in emergency medicine that if a person collapses, they're having CPR done, and you manage to get them back, they are not suddenly cured of all their diseases. The best they will come back to is whatever shape they were in before their heart stopped.
Yeah. What the phrase I use when I'm talking about this, and I try to have these conversations pretty quickly. I try not to be scary. I talk about easy stuff first, like what symptoms are you having, and then we talk about, I call it the big 3, or I call it the Texas 3-step, which is really corny. So the first step is, if you couldn't speak to me, who would be your voice for medical decisions? So, lightning struck you, you can't speak. Who would help? Who would tell me what kind of medical care you get, in an emergency? And so if they don't know, then I say, okay, good. Let's think about somebody you trust. And that's your homework. And I ask my doctors, my residents, my students to do this on admission. So when you're seeing them in the ER, somewhere between what do you do for a living and what are your allergies, is who is your voice? So that's not a super scary question, but it's an important question. We have to know who to call. I then follow that. If they haven't, thrown up because they're scared or they haven't asked me to stop talking, I'll say, my second question is, what is the emergency plan at your home? If you were found not breathing or your heart was not beating well, would you tell your family to call 911 and go to the hospital, or would you not? Would you have a different idea? And most of the time, number one answer, do everything, doc. Do everything you can. I want to live. I'm a fighter. She's a fighter. Do it. Do everything you can to help her live. And a lot of times I have to swallow hard and recognize that I'm not here to convince them otherwise. I'm here to give them options. I'm here to listen to them. And I can say, I hear what you're saying. What I'm hearing you say is that you want me to treat things that are treatable. So if I can make you better in this situation, or if the ambulance and CPR can help you kind of come over this crisis, and you have a decent chance of making it, and you have a decent chance of coming back at least as good as you were before this happened, then you're interested. And so I hear you. Now, if they have some horrible diagnosis and there's no way in the world that CPR is going to make them live better or longer, I may say that in a way that's a little less scary, which is to say, I hear you, and I mean, you can honor that, but you know what? It's important for me to say out loud that the people who do best with CPR are actors on television, not normal people like you and me. And in fact, most people that have CPR that are sick enough to need CPR don't live. But if they do, they come back sicker than they were, usually with a stroke. And so I'm not saying you are going to get this. I might say if I had a heart attack right now in the parking garage, I'm probably going to have a stroke as they try to bring me back. And so I'll give them a bit of reality, but I'm going to honor that. They say, I just do everything and I want to be full code. I can honor that and I can document it, but I'm also going to document kind of what we brought up. The third part of the 3-step, if I can get it, and again, you watch their eyes, and so if their eyes are getting bigger and bigger and they're looking more and more nervous and family members are pacing and they're looking at you like you're the Antichrist, then probably you should stop talking. And so but if they're listening and they're hearing me, they got that little reality check about whether or not CPR is going to make them live better or longer, then I'm going to say, now the last thing is an advance directive. This is called a living will in our state. And that the state of Texas asks, if you're at your very, very end, that is, if you have something terminal, that is, we can't treat it anymore, or you have something irreversible, say a really bad stroke that's not likely to get better, and your quality of life is expected to be very bad, would you want to be A, kept comfortable, but not on all possible machines, or B, given comfort medicines, but on all possible life support? What, have you ever thought of that before? And sometimes they'll say, yep, I've thought of it. And sometimes they'll go, I don't know why you're asking me this, doc, do everything. I'm going to say, okay. But when we're talking about treatable things and then not being able to treat, the vast majority of people will tell me, if they really hear me and they're facing serious illness, maybe they already been thinking about dying because they're up every night at 3 a.m. taking breathing treatments. Maybe they're already got it in their mind. Is just for me to be able to say, most people tell me fixable things, treatable things. But if what I have is not treatable or not fixable, and my life is going to be worse than it is now, I don't think I want that. And they will go on to tell me, I really never want all of that. So they may still be full code, but their advanced directive, if I can get them to complete it, may help their family know what to do if we have a terrible emergency tomorrow. Okay.
You know, Gawande talks at length. Have you read the book?
Twice.
Oh, it's marvelous.
Yeah.
I listened to it in audio tape driving around town, and it
Cried
was
like
just,
a baby. I cried from the first of it.
Cried like a baby. You know, I watched my father go, watched my mother go.
Yeah.
We put mom in palliative care, hospice, so forth. And so he gets in there and it says, mistakes we make as physicians is to present options that are not reasonable. A person has advanced cancer. They're really doing very badly. They're in palliative care. And the treatment is not working, and the doctor presents, there is a study that shows this chemical has a chance of it continuing your life from 2 to 4 months. It's pretty pricey. It's about $100,000. And do you want to do that? As opposed to asking the patient in what sort of milieu, since they have an advanced, almost certainly fatal illness, saying, what do you really want, at the end? I don't mean to get off, but this is right on the subject of something.
No, absolutely. Y'all, I could talk about this all day. This is, you don't want me to get into this.
I'll give
you some good resources to look at. This is the stuff you write your personal statement about. I mean, these are the ethical dilemmas that you do run into. You can see it coming. It's going to be tough, and it is. And so one of the things that primary palliative care teaching is how to anticipate. If I have to tell somebody something sad or that's going to scare them or make them angry, to tell them that there was a medical mistake, I need to be ready that if I'm going to tell them something serious, that there's going to be an emotion. the thing that we're afraid of when we talk to patients is we're going to tell them something that's going to make them very sad, or it's going to make them very angry at us, or they're going to be mad already, and then they're even madder.
These are truly life-changing conversations.
Oh my God, yeah.
I see so much nuance at cancer at Parkland in the ER.
Yeah.
You know, people come, they're coming from out of state, from Mexico or wherever, and they come in with an advanced illness.
Yeah.
And from which they're not, you know, it's breast cancer, it's already innumerable metastatic lesions in the spine. And yet they don't yet know it. And I wish you would address this. There's a period of time that it's always been a little conflict for me, that I know something that they don't know. And when I tell them that, it's going to be a life-changing experience.
And so, you know, all I can say, you know, every situation is definitely different. Again, when you are not yet trained, you don't have the bandwidth, you don't yet have the finesse. Don't get yourself painted into a dangerous corner. Listen, recognize if they seem to be thinking that there's a cure here and that they have no more cancer, and you're looking at the chart and their chest is full of cancer. That's when you go to your senior, you go to your attending, and you say, he doesn't know. They're not talking about it. Maybe there's a misunderstanding. And so it is important that you recognize it. So have your feelers out for that patient who may have an unrealistic idea. All patients have unrealistic ideas. That, you know, someone will come in with a terrible stroke, and in their minds, their loved one is still the same as they were last week, right? They're not ending now where there's a big giant stroke on the CAT scan and this is a very devastating situation. They're still in last week. What I would say is, if you're going to be telling something that might be upsetting to them, or likely would be upsetting to you if they were telling it to you, expect an emotion. And if you're expecting emotion, the way to deal with an emotional response of a patient or a family member or a loved one is with empathy. So vitaltalk.org is a wonderful tool. It's a wonderful website which has a lot of patient communication tools that you can use. It says, if you're expecting an emotional response, respond empathically, not with data. Don't just keep telling them data. Don't keep telling them numbers and statistics and odds ratios and all that stuff. Stop. And so there's a mnemonic called NURSE, which is fantastic. So one would be name the emotion. So if somebody seems upset, you seem upset. Okay, you've named it. I usually will notch that name down a little. I won't say you seem mad if they're not mad, because if they weren't mad, they may be mad now. So I will, this must be upsetting for you. You is understanding. Help me understand how you're feeling about this. I understand this must be very upsetting for you. Now, I understand is a little loaded because I might not be able to possibly truly understand. So I remember as a resident telling somebody, I understand you're upset. And that woman took my head off and said, you can't possibly understand what I'm going through. You don't have a husband of 50 years on a ventilator right now. And I'm like, you are so right. I am scum under your shoes, and there's no way I should have used the word I understand. But asking for understanding of the patient. Respect. You've really been working to fight this cancer. You've done everything you can to beat it. This has got to be really sad for you. So respect what they've been doing. Respect that caregiver that's been taking care of her mom with Alzheimer's for 7 years. We have respect for everything you've done. Never discount what they've done. S is support. We're here to support your wishes and listen to what you want or what your mom wants. And explore. Explore is if they say something like, I just can't do this anymore. Okay. Does that mean they don't want to do treatment anymore? They don't want to go to the doctor anymore? They don't want to live anymore? You don't know. So you can't really presume what it is they mean. So when you say, I can't do this anymore, tell me what you mean. Okay. So NURSE is a wonderful tool where you're responding to a sad or scary situation with a patient with empathy. And once you get understanding, if they're then ready to get more data, you can give them more data. But this is just a wonderful thing. And I just urge you all, no matter what you do, I don't care if you go into business, I don't care if you go into IT, you're going to deal with people that you're telling them something they don't want to know or they don't want to hear. And so to have just this one tool, it's a simple, very brilliant, beautiful tool called NURSE. And these are really smart people that have put this together. So I didn't even list all the Vital Talk training I've had. But it's a fantastic program. So vitaltalk.org, it's in the references. So I'll keep moving. I'm gonna stop talking. When I'm describing palliative care, I will tell them that it's for people with serious illness, serious symptoms, and maybe the need for serious decision making. And in this type of care, we focus on making your symptoms better, about teaching you more about your illness, and honoring your choices. If they still don't quite get it, I'm going to say, well, okay, so I grew up in a small town. So the West Texas definition of palliative care is to make feel better stuff that might be hard to fix. Okay. We're always about fixing and curing and reversing and making it go away. And there are things that we can't do that for. We can only make feel better. We can't fix. And so sometimes that's when the light goes on, is when I tell them I can't fix what you have, but I can make you feel better. And then we go from there. So it's just getting on the even playing field. Okay, I know I need to keep moving. Why do I love it? A million reasons. Okay, I love being able to decrease somebody's symptoms. I have 2 sites here that I want you to see, and oh boy, you can't read them. Oi. Okay, so one, palliative care feels a lot like family medicine for serious illness patients. Okay, and I've got a slide that's next. There's always something that we can do, even if it's small. We listen, we honor, we respect, we decrease suffering. There is a wonderful site. I want everyone on this thing to get on it, which is Dignity in Care. This is, if you look up the dignity question or you look up this site, it makes me cry every time I look at it. There's something called the Dignity Project or Dignity in Care. And this is an amazing way to get to know a patient better and to know them as a person, not an illness. I try to add it to my history taking, which is tell me something about you as a person that will help me care for you better. Okay. And they'll tell you, oh, I was a pitcher for the Yankees, or, oh, I really love cats, or, I do yoga, or I knew Mother Teresa, or, people will have something that makes them special that has nothing to do with their illness. And it just humanizes and brings back dignity. Makes me cry every time. The other one is that vitaltalk.org, which you can't see because it's green on green. So it's just basically
we found it and put it in chat already.
Thank you. Yeah, it's just fantastic. Okay, keep moving. I'm gonna keep moving. I've got to be like the shark. I gotta keep moving. Okay. I like the Venn diagram. I'm not a Venn diagram person, but put 3 circles together. What I think is so cool about it and why family doctors need to be doing more Pally and is because we have the same principles. It's patient-centered, family-centered. It's patient as a whole unit, not just a person, and certainly not just as an illness. We want to honor their medical decision-making. We want to use compassionate communication. And the parallels between family medicine and palliative medicine are really close. If my promise as a family doctor is to take care of a patient from womb to the tomb means the end. I've lost 5 really dear patients in the last 3 years, 2 of them to COVID, 3 of them to COVID. But I've been their doctor for all of this time. Some of them have died, I've lost to cancer. I have had a couple I've lost to strokes. So good or bad, I'm there. Good or bad, I'm there to listen. I'm there to support. I'm there to hug. We're there to talk about it. We're there to think about what might be next. We're there to talk about how do you do funeral arrangements. We're there to do whatever it is that they need that's helpful to them. Be a person that's helpful, like a guidepost. So there are a lot of parallels between those two. Okay. When should we think about palliative care? Not going to go on to this, but you got a patient with really bad disease, and they've got uncontrolled symptoms. Okay. We're supporting the patient and the family. Is there a lot of distress related to their treatment? Is there a lot of distress related to their disease? Do they have unclear goals of care? Do we not know what they want? Do they need help at very end of life? Are they very uncomfortable? Can we do something in terms of getting them on hospice care? What if they have brain death and they need to come off life support? How can we do that in the most caring and comfortable way that aids for the family and the healing so that their experience with death, as bad as it is not catastrophically worse? And so this is when we need to think about palliative care. And this is just about everybody that has serious illness. At some point, some aspect will be brought up during palliative care. We try to be just, like the Swiss Army knife. Okay, think of everything. what patients may benefit from palliative. And I'm going to go ahead and squish palliative and hospice together because the diagnoses are similar. Whoops, hepatitis is misspelled. Just think about organs. All right, we only have a few major organs. We got your brain, we got your heart, we got your lungs, we got your liver, we got your kidneys. Okay, we got your GI tract, we got your GU. Okay, these are major systems, right? The major organs, we only have a few. So what I see a lot and what really kills me, and it's making me teach primary palliative care to my residents from day one to day last, so 3 years of extra palliative care training in family medicine, is that how many patients get admitted every single day with heart failure that's in stage 3, kidney failure that's stage 3 to 4, they've had a stroke, and they have COPD. Those are 4 big major organ systems that are at risk. Okay, all they need is one more thing, cancer, or they need a bad infection, and we're in trouble. And people are full code and they're in the hospital all the time, and they don't realize how sick they are. They don't really have a good concept of where they're at in space. If we can help them recognize it, can we change the course? If we can't change their course, can we make that course better? And that's
Yeah,
really
Tamara, in the ER a few months ago, this woman in her 50s came in with advanced stage 4 metastatic colon cancer, broken bones everywhere, bed sores, just the worst of situations. And I was working her up to put her in the hospital, and she was from out of state and, a new patient for us.
Yeah.
So we were clearly going to admit her. And I noticed on the chart, it said full code. Really? Do you really, really want me to press on your chest and bring you back from this? Wouldn't you much rather have a controlled end that is comfortable as we can make it for you to be with your family and so forth?
Yeah, it's and I used to say, oh, it's all about denial and no denial, and they're just in denial and they don't understand. And that, one of the things that was hard for me to learn as I started doing this, but it makes sense, is that denial is a defense mechanism. All right, and it's very effective. And someone with stage 4 cancer in every bone in their body, and they're walking around, and they got to get up every day, cannot think every single day, I could die any minute. Otherwise, how do you even get out of bed? And so denial is useful. Someone in the room needs to have an understanding at some point of where we might be. And is there something reversible, or is there something we could make better by making the end more controllable and more pleasant and more comfortable and more on their own terms? And it's just super important. And I'll stop talking about this, but this is palliative care, and this is every organ system, congenital disease, and advanced kids. I had a kid who I just lost this year. She was 19 years old. She was a hospice baby. She had congenital herpes simplex encephalitis, which they didn't find until she was 4 months old because couldn't keep her temperatures and she wasn't growing. And so here I was on hospice, a hospice medical director taking care of kids on hospice. And so I admitted her to hospice, and we got her through her infancy, and then she lived, and she lived another 19 years, and died of COVID. So had great care for all these years, neurodevastated. Mom loved her, caregiver loved her, sister loved her, I loved her, but she was a hospice grad, so if you never know how long somebody's going to be there. All right. Symptoms to palliate. So the other thing is, if you can't talk to them about death and dying, but they clearly have lots of symptoms, you can talk to them about what's making you miserable on a daily basis. What symptoms are bothering you the worst? Now, Dr. Fowler would recognize these as bounce back symptoms. So remember when I told you about bounce backs when he was off the screen? Bounce back is somebody that comes straight back to the hospital. Despite everything you did for them, they're back within a couple of days. They bounce back to you. These are bounce back symptoms. If your patient has intractable pain, they're coming back. If they have intractable dyspnea or shortness of breath, they're coming straight back to you. They can't sleep, they can't eat, they're losing weight, they're going to come to your office. If they're now confused, they weren't confused and now they're confused, they're coming to the ER. If they're vomiting and they can't stop vomiting, they're coming to the ER. If they're pooping and can't stop pooping, they're coming to the ER. If they can't poop, they're coming to the ER. So they're all coming to Dr. Fowler, and they're going to be admitted to my service. And so, we have to look at symptoms and what can we do about them. And these are symptoms that everybody has, especially with serious illness. If we don't address these, we're not going to succeed at keeping them out of hospital settings and out of ICUs. So we're always looking for symptoms that we can palliate. Can't fix them necessarily, like to fix them. But if I can't, can I make them feel better? And, be ahead of it, be smart. All right. Whew. Questions? I don't know, Rohit, how are you doing? We want to ask some questions? I need to see what time it is. Holy cow.
Yeah.
Okay.
I'll ask a couple of questions. I'll just ask like maybe 2 or 3 questions here. So one question that's been asked several times in the chat, how do you deal with patients who have different end-of-life wishes than their family? And sort of as a related question, how do you approach a situation where the patient might not be, like in cultural situations, where the patient themselves isn't necessarily
in charge?
It's perhaps like the eldest son who's responsible for making the healthcare decisions.
That is a fantastic question. That is so nuanced, and that's such a smart question. And I don't have an easy answer for that. The best I can do, if the patient has decisionality, if the patient is able to understand what's going on, understand what's wrong with them to some extent, and I tell them I work for you, okay? Now, but it's a good idea when you're meeting them in the ER. You don't know that they have metastatic cancer yet, but they're super sick. They've lost weight. They've got small caliber stools. They've got bony mets or whatever on an X-ray. You want to find out. We're going to be looking to see what's wrong. It's helpful for me to know, how best do you like to make decisions? Do you like to hear all the information, or do you prefer that your husband or your wife filter that information? And you can tell some of them are just wiped. They're just so exhausted they could barely lift their head. And I'm going to say, we may be talking about some pretty complicated things. I want to tell you everything, but I need to know how you like to hear things. And I've had families stop me in the hallway many times. Don't tell mom that she has cancer. And don't tell dad that he's dying. Okay. And I appreciate that. As a loving family member, I can see why someone would want to shield that loved one from this terrible news, especially if that person has said, you make all the decisions for me. And it is very cultural, and I've run into that. And I will tell you, as a privileged white woman, with generic faith that says everybody needs to know everything and we need to say it out loud 7 different ways, to run into a cultural situation where it's not that way, it does thwart me for a minute. But it is not my job to beat them over the head with it. And I have to acknowledge that family is protecting that loved one. And I need to honor that, at least for now, because my other job, and when you go see a patient, is don't get fired, okay? If I go in, draw a line in the sand, I'm the doctor, you're the patient autonomy rules that I must tell you everything. I must tell you about all your cancer, regardless of what your family says. Hell with them. I know best, blah, blah, blah. I'm fired, okay? Now, I can't care for that patient ever again. And I may have ruined it for any other doctor that's going to talk to them about this. If I'm the worst palliative doctor they ever saw, do you think they're ever going to ever see another palliative doctor? And am I going to impact their bad death? Yes. So I have to honor the fact that they're there and they're there for them. If they stop me in the hall, I'm going to ask them to come. Do you mind if we talk for a second? And I'm going to grab them and we're going to go sit somewhere. And I'm going to say, here's the best answer. And this is the best answer on any board exam. Tell me more about your concerns. Okay. That is the best answer. You said you don't want me to tell her about her disease. Can you tell me what you're worried about? What do you think would happen if she knew? Okay, because that's where they're working. They're working on this. And I'll tell you the number one answer, she'll give up. Okay, he'll give up. He won't want to live anymore. He'll give up and he'll die. And I get that. I do. I understand that. I can't tell them I must tell him. I can tell them, I hear you and I have to respect what you're saying. I'm going to need him to, I'm going to need to know from him about his decision making. And I should have learned that already, okay, before we're running into the hallway with this question by asking him downstairs, who's your medical decision maker? Okay. And how do you like to hear your information? If I'm ahead of it, this isn't a surprise to me. And then we can start talking about it. Am I going to at some point talk to the family and maybe try and flip it and say, I hear you. She's really smart and she knows everything else. And she's run a family for 55 years. You don't think that she might want to know why she feels so bad, so that she can make decisions, or she can do different things. The hardest case that I had for a long, long time was a patient that was a Korean gentleman who had cancer, and it was really bad. It started as hepatocellular carcinoma, which he did not know about because he wanted his family to make his decisions for him. Now, he was totally lucid. He was like 55 years old, but his culture was that his daughters would make his decision, and his wife was third person to make the decision. And so it got worse, and he had mets in his liver and in his rib cage, and he had terrible pain, and he didn't. And I kept trying to say, what do you understand about this? Are you sure you don't want me to tell you what's going on? No, my family knows what to do. And it was just torture. And it wasn't finally until the dialysis nurse, because he was on dialysis also, who also spoke Korean. And we always used an interpreter. I didn't use the family as translators or anything. And I didn't try to convince him. It just tore me up because he kept asking, why am I hurting so bad? But when I wanted to tell him, he wouldn't let me. So I think he knew. And so finally, I finally said, what do you think's happening when you have that sharp feeling in your chest? And he said, I think that there is broken glass inside my body and that it's cutting me from the inside like knives. And I said, and why do you think that's happening? And he said, I think I was bad. And everybody burst out crying, everybody, including the interpreter. And finally, we just cried, all of us, because I thought that was just the saddest thing I could hear. Is that he not only did he not want to know that it was cancer, but he thought it was because he was bad. And so finally, I said, can I please tell you what's causing? Because it's not that you're bad. And we did. And he accepted the medication, and he accepted not going to the hospital all the time. He actually decided to come off dialysis so that he could get home and not be jostled in the car 3 times a week with the glass stabbing him up into his heart, with his horrible metastatic rib cage pain. And so that's a fantastic scenario that you ask about. What do you do when? And again, it's case by case, and you got to tread carefully. And you just have to sort of honor the person that you're caring for, but you can't disrespect the family. Not entirely. Now, if they're terrible or they're abusive or they're neglectful, then you get other help. Okay. But if it's a cultural decision and the patient is supportive of it, I can't just go in there and bulldoze them with answers, right? I have to take them as it comes. Makes sense. I'm sorry, all my answers are so long.
Not at all. That's fine. As a bit of a follow-up to that, legally speaking, is it acceptable for you to only share that information with the patient's family and not with the patient directly, at least at that time?
It has to have been spoken by the patient that I have a permission to talk to the family. That's your PHI, so your personal patient health informant. It has to be someone that they have said, yes, you can talk to my family about this. I cannot tell everybody in the room about their diagnosis without the patient's express permission. And so I'm going to try and make sure that I know that patient, who that patient wants to get their information from, and whether or not I can share it. Okay. And so, it's careful. You have to be super careful, because I'm a talker, man. I mean, somebody calls me and they want to know, I want to tell them. And that's not the right thing with HIPAA and with patient rights and things. You have to be super careful.
Thank you for that clarification. I'll just ask maybe one more question for now.
I'm almost done. If anybody's like dying, they're hemorrhaging, their toothpicks are falling away.
You're doing just fine. You got 220 kids hanging on the edge of the chair.
It's like that movie, Ray. Do you remember that movie Airplane?
Of course.
Yeah. So the guy sits down and the guy starts telling him his heartbreak story, and it starts and it's really long, and the lady goes, "Oh, they're there," and then the guy's like killing. He's like, I can't just take it anymore, and he's like, hanging. One guy catches himself on fire. I mean, the stories are too long. So
yeah. No, you're doing wonderful. This is so wonderful. Please keep going.
All right. Oh, this is crazy. This is gonna be on the internet. Oh Lord. All right.
Maybe one more.
Oh God. Well, let me get off this line. Okay.
One last
Okay.
question for now.
Let me tell you one more palliative case. Okay, this is another example of someone. So this is a patient, Mr. D. Absolutely lovely man, lovely wife. I was consulted on him about 2 years ago, about 3 years ago. He has horrible end-stage lung disease. Okay, he's got interstitial lung disease and COPD. He's got some coronary artery disease. He's had some stents. A previous smoking history, and basically interstitial lung disease or pulmonary fibrosis. The image in my head is like a rusted window screen. Okay, there's no malleability. There's no oxygen transfer across the alveoli. You listen to it; it sounds like broken potato chips. And so I'm really stupidly visual, and I do a lot of analogies with my patients. But interstitial lung disease sounds like air is trying to get through this rusted window screen and it won't go through. And so there's a lot of restriction and there's a lot of pain and pressure and tension and they can't get a good breath and they cough and it's painful and it's just a miserable disease. And so I first met him back in 2019 and basically his pulmonologist said, you have a bad diagnosis. Maybe you should talk to Dr. Mack. She's talked to you about symptoms and if your shortness of breath gets worse, there's some things you can do. And so we talked back in 2019. And we talked a little bit about goals of care. He already had very clear goals of care. He did not want to have CPR. His wife was his medical power of attorney. He already had a living will. It was all printed up. I just asked him for copies so we could have it in the chart. And so we would talk just a little bit about what we could do if things get worse. We talked about what he would want to do if he was feeling sick. Would he want to go to the hospital for stuff? He went in for pneumonia, got better, came out. So it wasn't a no hospital situation. It was just don't put me on a ventilator. And we sort of forecasted when hospice might be useful. So we talked about the difference between palliative care and hospice. And I said, I'm here, standing by. So let's talk again in a few months. Call sooner if you're feeling bad. If you have any complications or you go to the hospital, let me know and we'll talk some more. And so it was really lovely. And they've always been televisits. I one day would like to hug him because I've known him now a couple of years and we haven't seen each other in person. So there's never been a hug. And we can hug now. So in the chat, I'm going to ask, what symptoms do you think this person might have? So this guy with horrible, crispy lungs that don't work, and I can't read the chat, so we're just going to take some simple ones. I already named a couple of things. So
I'll jump. Short of breath.
Okay, short of breath, number one answer. Okay. What else might he have?
Fatigue.
Fatigue, yes, poor energy and fatigue. Okay.
Anxiety related to it.
Yes, if you can't breathe, you get anxious. If you're anxious, you can't breathe. It's a vicious circle.
And with the anxiety, the flip side, which is depression associated with end of life planning and so forth.
Exactly. So these are symptoms he had on that first visit that needed help. Okay, shortness of breath or dyspnea. He had some chest pain and some angina. He wasn't oxygenating. What happens when you don't oxygenate well? Everything that needs oxygen feels worse. So like
you can't get comfortable. You're not comfortable sitting up, lying down, and so on.
So you're not going to sleep well. Nothing feels good. Terrible energy, terrible appetite. He was on a lot of diuretics. If you're on a lot of diuretics, all your poop gets very dry. If your poop gets very dry, you get very constipated. I will have a bumper sticker in my head that says the world is constipated. In Pally world, it's true. And everything GI related is probably related to constipation. It's like 3 degrees of separation. Somehow constipation is making this worse in most people. Coughing and wheezing he had, depression and worrying about the future. So next slide is what we could do for it. All right. So again, being the most optimistic palliative hospice doctor I know, we talked about what we could do. So we talked about his continuous home oxygen and what could you do in a crisis? How many points could you go up? How many liters could you go up? And then when would you go back down? We got him BiPAP, which is that forced pressure through the chest, which pushes through that rusted screen, right? So we can get more air. Electrical fans. I can't tell you how many patients in the hospital with shortness of breath I have ordered a fan. Okay, so there's this cool reflex. So you know how your dog likes to stick his head out the window when you're driving, and have the wind blow in their face, and it's just so exciting, and they bite the air, and it's wonderful. Turns out we have that. There's a reflex right here. But if you blow wind in my face for any reason, I'm going to feel better oxygenated. I'm going to feel more relaxed. It's the breeze in your face kind of feeling. And this is a reflex. And so I would say that a really good hard fan in someone's face when they can't catch their breath is better than morphine for shortness of breath, although morphine for shortness of breath is very effective. Very low dose, and given it takes down ear hunger, takes down anxiety, actually has a little bit of a bronchodilator effect. Now, bronchodilators in an interstitial lung disease patient don't work that well because it's not a pipe problem, it's a screen problem. So it's really out in the interstitium. It's not the air size of the airways. So we're doing a bronchodilator is not going to relax the muscles around the airway and give you effective relief of their shortness of breath. And so, yeah, you can do some bronchodilators, but really you got to do other stuff. Chest pain and anxiety and angina, we might do nitro. We might do long-acting nitro like Endure or isosorbide. We may do nitro patches, calcium channel blockers, things that might make angina better. He has poor energy. We found that he was anemic. All right, he was chronically anemic. Wasn't very hungry. Wasn't eating much. We treated his anemia, gave him a transfusion, so he was able to oxygenate better. And we talked about energy conservation. If you feel a little better today, it doesn't mean you need to go spend 3 hours at Walmart. Okay. You feel a little bit better today. Let somebody else go to Walmart and you go sit in the park and enjoy something. Okay. Don't do everything you possibly can do if you're going to spend 3 days getting over it. So energy conservation is deciding what you need to go across the house for, and it better be worth it. I would say it's worth it if it's ice cream. Treat constipation, which affects appetite. I want you to think of that constipation as a slow drain. All right. Your stomach is the sink. Your colon is the drain. If you're not emptying stool very well over time, things just sit there. So they're not very hungry. Then they have reflux. Then they have nausea. Maybe it affects their breathing. Dr. Fowler has seen every form of constipation ever, the worst forms you could ever see. And so we started treating his bowels, which took some of the tension off of his diaphragm because his belly wasn't full and bloated, and he was breathing better.
Dr. Mack, one of the worst orders you can write in the emergency department as far as getting the nurses to hate you is enemas until clear.
Yeah. Yeah. The best treatment for constipation is prevent the constipation. And then you got to know what to do. And my hospice nurses taught me a whole lot about constipation and something called the hour of power, which is another bumper sticker, which is there is no max to Miralax. But basically you just gotta, there's a way to treat it. That's a whole nother lecture. But we did address his depression, his anxiety. We did start him on an antidepressant. We did get him into some talk therapy and additional support for him and for his family. And we talked more about future goals. And so we clarified what he didn't want to have happen, which is CPR, chest compressions, and ventilators. He was then comforted by the fact that we had an out-of-hospital DNR made. That he did not have to worry about that happening. He didn't have to worry about his family not knowing what to do. And so that decreased. So we palliated his worry. And so that's just really awesome. He was just the most wonderful person. These are an example of palliative care communication goals, helping the patient understand what to expect. There's that pregnancy book called What to Expect When You're Expecting. I really think there ought to be a what to expect when you have a terminal illness. And we have several books and resources that helps you understand about those things. What resources are there? How can we help make medical decisions based on your values and your choices? How can we match the patient goals and values to the type of care we give them and offer them? And how can we explore those benefits and burdens of those treatment options? This seems really basic, but if you don't write it out or you don't think about it, we skip over from this is what the book says to this is what we recommend. And there's a whole lot in between that's really missed. And so we really just like to pick it apart a little bit more. Where can you get palliative care? Pretty much you can get it as an outpatient, get it as an inpatient. It is sort of regional. In the Northeast and the Northwest, there is some outpatient palliative care. There are some outpatient palliative care programs that are home-based. In the South and in the Midwest and in the Southwest, mainly most of the home-based palliative care is via hospice, okay? And they're not the same, and we'll get to that. But it's not available everywhere because Medicare is not quite sure how they want to pay for it. but palliative care is not restricted to a terminal diagnosis, and it's not restricted by time. These are who pays for it. It's lots of disciplines involved, and it may help with patient transitions to hospice if they're already there or they're approaching that. So hospice, you've heard about hospice. I don't want to tell you all about hospice, but it's home-based medical care in general for people with very short prognoses, usually 6 months or less. 6 to 12 months or less is a decent way to look at it. And it's all those things that I said palliative patients will have: heart failure, coronary artery disease, pulmonary hypertension, COPD, advanced cancer, renal failure, liver failure, stroke, CVA, multi-system atrophy, ALS, end-stage AIDS, etc. So all of these things that their time is getting shorter, and we can see that. So we step up their care, pay for medications that relate to their symptoms. We pay for equipment so they can be at home. We cannot provide custodial care. I'd love to say, here's Inga. She's going to be with you until the end of your life. Medicare will not pay for that, but we can get you a care aide that can help with your personal care. Your family may need to step up, or there may need to be some higher aid care, or we may need to go to a facility where you can also continue to get hospice care. We have to, you as the referring physician, have to say what your patient could be dying from, and then you need to send me records so that I can look at it and review it. And then we need to agree about every 60 days if they still look like they could die from this, okay? My number one graduates from hospice are dementia patients who look terrible when we admit them, but they look terrible because they're failing to thrive and they have dementia. And when we decrease medications, we stop going to the hospital for everything. We take them off things like their bisphosphonates and their statins, and we treat their pain with Tylenol so that they're not stiff. They live longer and they graduate. And so I have things that I will look for before I will have someone come on to hospice for a neurologic diagnosis. These are the differences between hospice and Pally. Not going to go over them, but you can see side to side that they have the same principles. All right. These are all about comfort and autonomy, choice, education, honesty. Okay. All of those things. It's just how long and where. Okay. And so that's what this slide is about. All right. Miss L, we'll just go ahead and go. Now that was our first lady we talked about with the mom who we talked about. So about a year before her mom passed from COVID, Miss L developed hemoptysis, that's blood in the sputum, and a worsening cough. Remember, she smoked for many years. We had done a screening chest CT about 3 or 4 years before, but she had a lot of social difficulties getting to the doctor. She didn't drive. She couldn't get to appointments. She didn't keep up on screenings a lot of times. So when her cough got worse, we got a CAT scan, showed a large mass in her chest with Mets already. So she was stage 4. And I palliated those symptoms. So she got palliative intent radiation. So the radiation was to shrink the tumor size. She said that she wanted treatment, but she didn't want treatment that was going to make her vomit and make her sick all the time. And so she went with palliative intent chemo, a lot of immunotherapies and adjunctive therapies that she could tolerate better. She did pretty well with them for a while. I managed her pain. She had some neuropathic pain from the rib involvement because there's nerves below each rib. And so as the effusion, the fluid pockets in the chest from the cancer got worse and it was irritating the lung, we added more for neuropathic medicine. Hydrocodone was still her medication of choice. We tried her on long-acting morphine. She was too sleepy. We tried her on fentanyl patches. It didn't work. So hydrocodone was her drug to her very end. We had a lot of goals of care conversations. She didn't want to go to the hospital anymore. She wanted to still have CPR until the last big hospitalization. She had 3. Let me get to there. So she had 3 hospitalizations during that last few months. One was a community acquired pneumonia. One, she had urosepsis. And one, she had neutropenic fever related to her chemo, which was then stopped. So when we stopped chemo and her metastases worsened, we had more conversations. And while she still did not want to say she never wanted CPR, she agreed that she did not want to come back to the hospital. She wanted to stay at home. Her daughter was her caregiver and wonderful girl. Very much difficulty, very financially strapped, but did a fantastic job. We got her on hospice. Hospice saw her just about every day because her symptoms were high. They called me for symptom issues and updates. I saw them a couple times at their home. And then meanwhile, her mom got sick and died, and Miss L died about 2 weeks after her mom passed. They weren't able to have a funeral until many months later because of COVID. But I was privileged to be able to attend her memorial. And it was beautiful. It was absolutely beautiful ceremony. I cried like a baby. And I still hear from her daughter sometimes. And so it was a really meaningful experience. I took care of her for 12 years, palliated a lot of things I couldn't fix, but we didn't call it palliative care because it was just everyday life with badness. And then as we got sick and as she became sick with her cancer, and it really became a real palliative care case. And then it really became a hospice case. And so, again, what was meaningful to me is that I was there for it all. And we went through it together. Not going to talk about hospices. They're all the things that hospice does and who pays for it. The rule on palliative care is that people that get palliative care generally live longer than patients that don't with the same diagnosis. And the same thing is true with hospice. Hospice patients usually live longer than patients with the same diagnosis. It is because we make them more comfortable. We give them choice. We help them be surrounded by people they want. If you're miserable, you don't want to live much longer. If you're comfortable, you live longer. And so it's never a surprise to me when somebody lives longer than we expected. Further on Mr. D, saw him in the spring with another telemedicine consult, talking about his symptom management. We have all his documents. I heard from him again in January, so he was pretty okay then. In January, he'd been in the hospital again with volume overload, heart failure, and some respiratory distress. He's treated for bronchitis and IV and fluid overload and went home. So we went ahead and had a telemedicine visit then to address his symptoms. And so his shortness of breath wasn't relieved at all now with oxygen or by PAP. It wasn't relieved by nebulizers at all. So the bronchodilators were no longer effective at all. We'd gone up to 8 to 12 liters of oxygen at a time. He was now not really able to transfer well. He's not able to walk because of his breathing. And he was really, really tired, really tired. And so we talked about, whether or not he would want to go to the emergency room or not. So to ED or not to ED, that was the question. And his goals were clear, and he clarified it again. His wife was clear and let the adult children know that what they wanted. And we confirmed that his orders and his documents were in place. I did ask him to try morphine concentrate to take when he was feeling shortness of breath, that rest, oxygen, and fans weren't helping. And he agreed he would try it. And we talked about hospice, and they decided that no, in January that he wasn't quite ready for it. If he needed to go to the hospital, maybe he would go to the hospital, but he didn't want CPR. Weren't quite ready. The number one answer when you ask somebody about hospice and you say, do you think maybe I think it's about time we try hospice? Number one answer, oh, we don't think we're ready yet. And I appreciate that. Everybody's optimistic and nobody can see it when it's them, right? And so that's always the number one answer. Got another call about a couple of weeks ago, very recent conversations. He'd started losing weight despite trying to eat, no appetite, no energy, worse angina, worse shortness of breath, worsening sense of foreboding and doom, and said, I think we're ready for hospice. And so what I do as his referent is I gather his information, his payer source, the last time he was in the hospital, his med list. I need to send an order to the hospice to say admit to hospice, and I need to tell them what he has. And then I tell them who to call and how to get in touch with me. And so we've started that. And so they're at peace. I will be getting in touch with them. I may have to make a house call so that I can hug this man and his wife. And so I'm looking forward to that because I'm not going to make him come to the office. Summary. Okay, this is when everybody goes, oh, thank God, she's not going to talk anymore. So in summary, these are sage pieces of advice. So one, I want you to just keep your mind and your heart open to your future. You don't know what your future holds, and you don't know what you're going to do. You know what you want to do. But until you've had a chance to see it, feel it, smell it, taste it, touch it, see somebody else do it, then give yourself that opportunity to experience all the choices and the possibilities before you settle in. And then choose family medicine. Ha ha ha, no pressure. My mom taught me to look at my life in about 4 to 5 year increments. Now we call that delayed gratification because look how long you've been in school. So, you're in school for 12 years, and then you're in school for college for 4 years, and then maybe you do that gap year, which becomes 3 years, and you do that extra degree, and then you're trying to get into medical school. And it's all about when we get there, then we're going to finally be there. And so you do that for a long time. If you look at it and say, look, you probably didn't marry your first girlfriend. Okay. Your first job will probably not be your last job. Now, do make sure your first spouse is your only spouse if you can help it. All right. But do try to morph your life according to what's coming. So when I went into practice, I was kind of part-time. And then when the kids were at school, I was more full-time. And then when they needed me more, I was more part-time. And do try to look at things and say, okay, what things do I really love? And can I do more of those? And can I do less of that crap that I don't like? And if you stick around and become dependable and people depend on you and they trust you, then you get to do that. So me as the oldest, I'm the second oldest person in my department now. And I'm kind of that old lady where I can sit back and go, yeah, point of care ultrasound is really cool, but I'm probably not going to learn that at this point. I'm going to let the youngsters do that because they're better at it. I'm going to do sage stuff. I'm going to do more of this stuff. And, but it's really cool that you're doing it. And not have jealousy or FOMO because somebody else is doing all this cool stuff. Pay attention to your own wellness and that of your loved ones. I was guilty of not doing this, and I'm still probably not as good to myself as I should be. When in doubt, just listen. Okay, listen to your heart, listen to what they're saying. I love this phrase, and I cannot say it. It was listed as like some unknown physician in like 280 or whatever. It was a cure sometimes, treat often, comfort always. Thank you so much for the time. Is there any questions? Y'all let me know.
Oh, what a magnificent talk, Tamara. That's just wow. You've had over 220 kids sitting here going, holy cow, this is what medicine is about.
You poor things. I'm so sorry.
No, womb to tomb, this is exactly what we needed to hear. And you must be exhausted. And I think what we'll do is to let you off the hook.
Well, if there's anything hanging, you can give them my email, or if somebody's got questions, I can stick around. I'm not headed home just yet. Yeah. Lee is fed, and he knew I was going to be here for a while. So,
yeah. Can you see chat at all on your computer?
Yeah, I can pull it up. Let me stop sharing.
I want everybody to put, we'll skip this Q&A session. I want everybody to put thank you into chat so that our guest can see it.
Well, we don't have to skip the testing if they need it for credit, but I'm not going to go over with them. They can.
Yeah, no, we won't go over the test now. And you need to go take a break and be with your wonderful family.
All right, let me get
Could you go back to that slide just for a second? We want to show that last slide so we can give them the QR code.
Sure. We got it. Did I stop sharing?
Yeah, you stopped sharing. So
how do I get back there?
Rohit, do you have the talk handy?
I
can pull it up.
Yeah, pull up the QR for them. I'm not sure. I can try and share it. We get back there. Oh boy. Long talk. Nobody should give me that much time to talk. That's dangerous.
I want to, Aditya is putting in the chat today's quiz link session. So please make sure you take it down. Okay. And also the bonus session that you can go back and take the session before. Rohit, are you anywhere in here? Yes, just share it, and let's share that last slide if possible. If not, we won't sweat it. We'll send the QR code out through virtual chat.
Do you see it now?
Not yet.
Okay.
No, and I'll tell you what.
I can share it from my end.
Okay, you share it from your end. All right. It's so hard.
I can see it.
Well, my questions were insultingly easy. He added some.
All right.
All right.
So Rohit, take it away and then turn it back to me for just a minute.
And God bless you guys. I wish you the best. This is a good profession. Everything related to taking care of people is so important. Everybody does not have to be a doctor to do wonderful things in this world. We need every single person. We need everybody just to care.
We've had 102 of these lectures over 2 years. And Tamara, your warmth of your heart is so outstanding across all the speakers that we've had. Thank you so much. Rohit, you want to touch
Yeah.
on the quiz information?
So here's the quiz information for this session. It'll be due next week at 6:59 p.m. Central Standard Time, just before our next session starts. You have 2 attempts to score at least a 70% or better, and please remember to download the certificate. Here is the QR code that you can scan, or you can also use this link, and you can also access the quiz on our website, which is virtualshadowing.com.
That's right. Well, folks, what a great session to end our 2 years. Tamara, this is a celebration for all of us.
Well,
And thank you so much for your kindness and your grace. You have just presented the breadth of fields linking family medicine to palliative care to hospice that is the future of medicine, as far as so many writers have addressed, and we all know that. So everybody, thank you for coming. This has been a terrific session. Dr. Mack, we are going to place your talk on our website.
Cool.
We have about 5,000 people will watch it. Each one of them will become a medical provider and probably see 100,000 patients in a career. 5,000 times 100,000 is 500 million. Tonight, Tamara, you've touched 500 million lives. And so,
All right, you got me crying.
Yeah, that's go. I'm a little misty myself. Well, everybody, we want to thank you for coming. This has been a terrific session. We'll be here next week with a really exciting speaker, the artist that we mentioned, who will be drawing cell membranes, thyroid cancer surgery, and so forth. It'll be absolutely fascinating. So on behalf of Dr. McGregor, on behalf of the virtual shadowing team, we want to thank you for coming. And we wish you a good evening and love.
Thanks, guys.